If you're a medical student, you know the feeling. The information overload is real. So today, we're going to cut right through all that noise. I'm going to show you a simple but really powerful blueprint that you can use to learn any disease, from something common to the rarest syndrome you can think of. So let's just dive right in. You're staring down a new condition. The textbooks are stacked high, your notes are a mess. Where do you even start? Honestly, it can feel like you're trying to drink from a fire hose.
But here's the secret. It is not about more memorization. It's not about cramming more facts into your brain. It's about having a better system. We've got to move from that chaotic pile of facts to a clean, organized blueprint, a framework that does all the heavy lifting for you so you can learn it, remember it, and, this is the key part, actually use it when it counts.
Okay, here's the game plan for today. We're going to start with the problem. Then I'll introduce you to our blueprint. After that, we'll put it to the test with two very different infectious diseases, compare them head to head, and then we'll talk about how this all applies way beyond your exams.
First up, let's just acknowledge the dilemma. The information overload. You know exactly what I'm talking about. The sheer volume of information is staggering. It's why resources like Durkot exist, right? They talk about the need for powerful revision tools that cut through the noise. Well, that is exactly what we are building right now.
And this is it, the disease blueprint. Think of it as your key to structured learning. It's a super simple, 5-step framework that gives you a consistent structure you can apply to literally any clinical topic. It's designed to turn that feeling of chaos into absolute clarity. The blueprint is built on 5 simple, logical questions. First, the what. What is this thing? Second, the why. Why does it happen? Third, the how. How does it actually show up in a patient? Fourth, the proof. How do we know for sure? And finally, the fix. What are we going to do about it? What, why, how, proof, fix. Simple. Let's see it in action.
All right, it's time to put this blueprint to work. Our first case file is a really serious heart condition, infective endocarditis. We're going to walk it through all 5 steps.
Okay, step 1, the what. So what is infective endocarditis? Well, it's an infection of the endocardium. That's just the fancy name for the heart's delicate inner lining. But the real danger, the really scary part, comes from what the infection builds. These nasty clumps called vegetations. Seriously, just picture it. A destructive mix of bacteria and blood clots growing right there on your heart valves, blocking blood flow and just chewing them up.
Step 2, the why. So what's causing this mess? It's almost always bacteria. But, and this is a big but, not all bugs are created equal here. It's absolutely crucial to know the 2 main players. You've got Staph aureus, which is the aggressive one. It causes a fast, really destructive infection. And then you have Strep viridans, which is more of a slow burn, a gradual kind of illness.
Continuing with the why, let's talk about who's at risk. You can think of it like a perfect storm, right? You need 2 things to happen for endocarditis to take hold. First, bacteria need a way to get into the blood. And second, there has to be a rough surface inside the heart for them to grab onto. That's the common thread that connects all these different risk factors, whether it's dental work, IV drug use, or having a prosthetic heart valve.
Okay, step 3, the how. How does this disease actually present? And this is where it gets kind of wild. How does a problem in the heart show up on someone's fingertips? Well, these signs you see here are classic high-yield exam material, and they're all caused by the same thing. Tiny little fragments of those vegetations breaking off, traveling through the bloodstream, and getting jammed in small vessels all over the body. Now for step 4, the proof. How do we nail this diagnosis for sure? Clinicians use something called the Duke criteria. Honestly, the best way to think about it is like a courtroom case. The major criteria? Those are your smoking guns, undeniable evidence, like finding the bacteria in blood cultures or actually seeing the vegetations on a heart ultrasound. Then you've got the minor criteria, which are like all your supporting clues, things like a fever or having a known risk factor that just make the case that much stronger. All right, so we've deconstructed infective endocarditis. Now let's switch gears and see if our blueprint is versatile enough to handle a super common respiratory infection, pneumonia.
Back to step 1, the what. So what is pneumonia? It's an infection of the lung tissue itself. So instead of the heart lining, our focus shifts to the alveoli, those tiny air sacs where oxygen gets into the blood. The core problem here is that the infection causes these sacs to fill up with fluid and gunk, which, well, it makes it pretty hard to breathe. Step 2, the why. Once again, we're hunting for the culprits. For the most common type of pneumonia you'll ever see, Streptococcus pneumonia is public enemy number 1.
But our blueprint reminds us to think broader, right? We also have to consider viruses, those so-called atypical bacteria, and even fungi, especially in patients who are more vulnerable.
Now for step 3, the how. How does pneumonia present? Well, the symptoms are what the patient feels, the fever, chills, that nasty cough, and a sharp pain when they try to breathe. But on examination, when you put a stethoscope on their chest, you find specific signs. And those crepitations, those crackles you hear, that is literally the sound of air bubbling through those fluid-filled alveoli.
And step 4, the proof. For pneumonia, the diagnostic cornerstone, without a doubt, is the chest X-ray. It gives you a direct visual of the infection inside the lungs. Sure, other tests like a sputum culture or a blood count provide important supporting details, but it's usually that X-ray that really confirms the diagnosis. Okay, we've run both conditions through the blueprint. Now for what I think is the most powerful part, putting them side by side. This is where the patterns and the key distinctions really pop.
And here it is. This is the payoff. Because we use the exact same framework, the key differences become crystal clear. Heart versus lungs, a heart murmur versus crackles, an echocardiogram versus a chest X-ray. And look at the fixed step. A serious heart infection requires weeks of IV antibiotics, while a simple pneumonia can often be treated at home with oral amoxicillin. This is how the blueprint makes these distinctions stick.
So, we have our framework. But this is about so much more than just passing your next exam. It's about translating all that book knowledge into real-world clinical competence. The ultimate goal of any learning tool, like the revision guides from DRCAT say, is to elevate your academic performance and ensure your success. A system like this blueprint does exactly that. It helps you build a deep, structured understanding that lasts, instead of just cramming facts for one test.
And here is why this really matters. When you're standing by a patient's bedside, your brain isn't going to be scrambling for random facts. It's going to automatically access this framework. It will systematically think through the case: what, why, how, proof, and fix. That right there, that is the essence of clinical competence.
So, we've laid out the foundation. This 5-step approach works for cardiology, for neurology, for gastroenterology, for any topic you're going to encounter. You have the blueprint. The only question is, what are you going to build with it?